Look ahead.
Well, good morning. I'm Tim Sheehy, President of the Metropolitan Milwaukee Association of Commerce, and welcome to another edition of the Business of Greater Milwaukee. BGM is a monthly webinar providing forward-looking insights on the business of Greater Milwaukee. This series puts a spotlight on the challenges and opportunities we face in sustaining and growing the region's prosperity. We hope these insights will help shape your business and inspire you to act out in shaping the region's future. We're again joined by Dr. John Raymond, President of the Medical College of Wisconsin, for the latest on COVID's impact and the vaccine rollout. In addition, we have two other distinguished education leaders to discuss the impact of the UW system. Mark Money, Chancellor of the University of Wisconsin-Milwaukee, and Becky Blank, Chancellor of the University of Wisconsin-Madison. The UW system has an estimated $24 billion economic impact directly and indirectly, generating 167,000 jobs. The UW system is an engine for innovation, a source for talent, and draws to Wisconsin over $1 billion in research funding annually. So these two institutions, one down the road and one in our neighborhood, do impact the business of Greater Milwaukee. We'll explore some of the challenges they faced with a tuition freeze, stagnant state funding, and changing demographics. But as they say, first a word from our sponsor. Today's program is sponsored by United Healthcare. In times like these, a traditional healthcare plan may not be the best fit for your business. So take a closer look at All Savers alternate funding from United Healthcare. MMAC has partnered with United Healthcare to offer coverage for groups of 5 to 99 employees. Now, small businesses can take advantage of the benefits typically reserved for larger companies, including underwriting for more competitive pricing, better data so your business understands where your premium dollars are going, and a potential surplus to refund claims if they are lower than expected. So contact your broker or visit uhc.com/MMAC to learn more. I'd also like to promo a virtual event on March 10th featuring Peter Zion, a geopolitical strategist and best-selling author. He'll help leaders analyze the complexities of the global economy in a post-2020 world, as well as the geopolitical risks and opportunities that lie ahead. Join us by registering at mmac.org/calendar. So again, we're grateful to have Dr. John Raymond, President of the Medical College, as our guest. Dr. Raymond, we look forward to the update on COVID and the rollout or continued rollout of the vaccines.
Yeah, thanks, Tim. And it's an honor to be here today with you and our listeners, and especially with Chancellors Blank and Money. We're really blessed to have such fantastic leaders in our community. Today, I want to go over some of the usual metrics that we follow for COVID-19, but also pivot in the second half of my presentation to talk a little bit about COVID-19 vaccines and where we stand. So if we go to the next slide, please, Chris. Thank you. Starting in the upper left, I want to show that we have tested almost 3.1 million people in Wisconsin. So that's more than half of our population have been tested for COVID-19 since last March. And of those, about 550,000 have tested positive during the course of the pandemic. So nearly 10% of the population of Wisconsin has had PCR documented COVID-19 at some point during the pandemic. It's likely that this actually represents perhaps half of the actual cases that we've had in our state, but we're still nowhere near herd immunity. Looking toward the bottom of the slide, Milwaukee, in terms of representing per capita population, has about very similar numbers, nearly 500,000 positive tests and nearly 500,000 tested and nearly 100,000 that were positive during the course of the pandemic. If you want to download the handout, we also have some historical information in the green bar at the right-hand side of the slide. Next slide, please. Just in terms of daily positive cases, the good news is we're having a significant downtrend in the number of daily cases reported, and I think you can see that. In Wisconsin, we only had 543 positive cases yesterday. Also good news, our case positivity rate is trending down at 14.6% yesterday with a 7-day average of 19.4% in Wisconsin. Again, similar trends and similar numbers in Milwaukee on the bottom of the slide with 74 positive cases, 12.6% case positivity yesterday, and a 7-day average of 19.3. Now, although these trends are favorable, I do want to point out that we're still significantly above levels that we were experiencing during the second surge of COVID-19 last summer in terms of new cases. When we would have a day of 200 to 300, that would be considered a high day. The case positivity rate also is unacceptably high. We want that to be significantly below 5% for a sustained period of time. So the trends are favorable, but we still have a heavy burden of disease in our community. And next slide, please. Just in terms of hospitalizations, we are approaching 25,000 people hospitalized with COVID-19 in Wisconsin since the beginning of the pandemic. Inpatients also are trending downward, which is favorable, at 572 inpatients in Wisconsin yesterday. That's a week-over-week decline of 114 patients and down from our previous high of nearly 2,300 in mid-November. If you'll recall, in mid-November, we were the epicenter of COVID-19 in the United States, and our health systems were full. And it also came at a time when many of our healthcare providers were out sick with COVID-19 or in quarantine from documented exposures. So we came very, very close to overwhelming the capacity of our health systems, but just barely made it. If you go to the right-hand side of the slide, we're down to 134 ICU patients. That's down 10 week over week and down from a high of 456 in mid-November. Still, these levels are higher than the ones we were experiencing during the second surge in last summer. Available ICU beds are also increasing. That's a favorable trend at over 300 now for the first time in a couple of months. And as you'll recall, last summer, we typically had anywhere between 350 and 400 ICU beds available. So we're still not in as good a position as we were in midsummer. Plenty of ventilators. As I've said before, we'll never have ventilators be a limiting factor in our ability to take care of COVID-19 patients or anyone else who needs our care in Wisconsin. And then in terms of personal protective equipment, those trends are stabilizing. We still have shortages, especially of gowns, goggles, and paper masks, but an adequate supply to get us through a week. We came very, very close in November to running out of some of these key personal protective equipment. I can go to the next slide, please. Cumulative deaths, we have surpassed 6,000 deaths in Wisconsin and 1,000 deaths in Milwaukee. And also, as I point out many times in the past, there is a male predilection for bad outcomes for COVID-19. And you can see about 54% of the deaths were male in Wisconsin and in Milwaukee. And also a slight overrepresentation for African Americans for bad outcomes with COVID-19 at 7.2% in Wisconsin and 25.6% in Milwaukee. So that is in excess of the population demographics. Although I want to make sure everyone understands this disease also impacts Caucasians and people that self-identify as white. And in fact, almost 83% of the deaths in Wisconsin have been Caucasian or white, and almost 58% in Milwaukee. And that trend shifted toward white and Caucasian deaths as the pandemic matured and evolved and spread throughout the rural parts of our state. And then finally, 6% of the deaths in Wisconsin and 12.7% of the deaths in Milwaukee were self-identified as Hispanic or Latinx individuals. There is an interesting observation with this population. They tend to be more likely to be diagnosed with COVID-19, but less likely in terms of diagnoses and, in fact, representation in the population to have bad outcomes. And we actually don't understand that. But the populations that have a disproportionately bad outcome that we need to think about as we roll out the vaccines in Wisconsin would be African American, Hmong, and Native Indigenous North Americans. Next slide, please. Good trends here with some of our indicators. Our doubling times are lengthening again, which is good news. So we're at 60 days in Wisconsin and 96 days in Milwaukee. Although I would have to say, with over 500,000 diagnosed cases in Wisconsin, if things don't change, it means 60 days from now, we'll have another 500,000 cases. So we need to improve. Similar trends with the 7-day growth rate moving in a favorable direction, 0.2% both in Milwaukee and in Wisconsin. But again, when you're talking about a large number of cases, that still means if things don't change, we're going to have continuing large number of new cases diagnosed. And then finally, the R number, which is a measure of contagiousness and ideally should be significantly below 1.0, is below 1.0 at 0.84, both in Wisconsin and in Milwaukee. And we've actually been below 0 now for a little over 3 weeks, or below 1.0 for a little over 3 weeks. But we would ideally like that number to be significantly below 0.5 if we're going to rapidly get control of the pandemic. And I do want to point one thing out on the bottom right-hand side of the slide in the green bar. We have a 1.1% mortality rate in Wisconsin for COVID-19. That's better than the national average, which is running just shy of 2%. I would attribute that to the high quality of healthcare we have in Wisconsin and the fact that we never completely overwhelm the capacity of our health systems. But I do want to point out that in October and early November, that death rate was 0.8%. And it started to trend up as our hospitals filled up. And it lagged a little bit because, as we've said before, you do know that the deaths lag between 5 and 6 weeks after cases are diagnosed. Next slide, please. Now I want to pivot to the vaccines. Most of you know that we have 2 vaccines on the market, Pfizer and Moderna vaccines, that both have emergency use authorization approval from December. And these are relatively new technology vaccines using messenger RNA technology. I want to point out that the technology has been around actually for about 20 years, but there has never been a mass marketed mRNA vaccine product. This is an issue for us because it hampers the supply chain. There's not a ready-made turnkey manufacturing capacity for these vaccines. And this is a limiting factor for us right now, and one that's very, very important. I want to shift to the right-hand side of the slide and talk about new potential market entrants. Novavax, AstraZeneca, Oxford, and Johnson & Johnson vaccines are very likely to apply for emergency use authorization and get approval in the next few weeks. In fact, Johnson & Johnson's 1-dose vaccine applied for emergency use authorization last Friday and will be taken up by the advisory committee of the FDA on February 26th. And this is important because our bottleneck is supply right now. And the Johnson & Johnson, AstraZeneca, and Novavax vaccines use an older technology. They use a modified adenovirus or cold virus to introduce the snippet of genetic material from the COVID-19 vaccine to create the antigenic response. The reason this is important is there is turnkey manufacturing capacity, both in the US and abroad, that can be easily contracted for and crank out hundreds of millions of doses very quickly. So getting Johnson & Johnson and one or more of these other old technology vaccines on the market could be a game changer for us. If I could go to the next slide, please. Just want to say thank you to the Department of Health Services in Wisconsin for trying to provide transparency in terms of the vaccine rollout. This is a screenshot from 1 week ago, and I would point out that the update will happen this afternoon today. It's done weekly, just showing various categories of vaccines in Wisconsin. So they're broken down into allocated. So the federal government has allocated or promised nearly 1 million doses to Wisconsin. We have ordered 770,000 doses based on the capacity of the clinics that we've stood up over the last 6 weeks. And in transit, so they're not actually in the hands of vaccinators yet, about 130,000 doses. And again, these data are a week old. As of that, we had administered 767,000 doses. Now, early in the pandemic, there was a lot of hand-wringing and even some finger pointing that maybe we were slow to stand up our vaccine clinics. Most of you have heard from me that there were a number of reasons for that in Wisconsin, but I also said that the difference between vaccinating, say, 2% of the population and 5% of the population from a public health perspective was immaterial, that we were far short of getting to 70%, and that it was more important in Wisconsin that we stood up a durable and sustainable capacity in a responsible way, and we have done that. So now 10% of the Wisconsin population have received at least one dose of COVID-19 vaccine. And as of yesterday, 165,000 people had completed the series at 2.8% of Wisconsin's population. And I just looked at the Johns Hopkins COVID-19 Research Center this morning, and this compares to vaccination rates or completion rates of the series in our neighboring states of Michigan at slightly better than us at 2.85, Minnesota slightly behind at 2.79, Iowa 2.77, Illinois 2.32. So we're actually doing better than our neighboring states for the most part. The best in class, so to speak, is West Virginia at 5.8% completion. I do want to make sure everyone understands West Virginia is a unique situation. They received a lot of doses of Moderna vaccine early. That is a less fragile vaccine that allowed them to push the vaccine out into their local pharmacies to administer more quickly to the population. We received quite a bit of Pfizer vaccine, which required cold chain transportation, storage, and really presented significant logistical challenges in distributing the vaccine in small aliquots to frontline clinics. I think we've solved many of those logistical problems now, and we have 16 vaccine hubs that have been stood up in the state that are now very capable of distributing small amounts of Pfizer vaccine to frontline healthcare providers and clinics. Now, just to compare where we are to the average in the US, 2.5% of Americans have completed their series. So as opposed to early in the pandemic or early in the vaccine rollout, when we might have been lagging a little bit, we're actually doing better than most other states. Next slide, please. I'm not going to spend a lot of time on this. Many of you know that we're trying to phase the rollout of the vaccinations. As long as the supply chain is our limiting factor, we're going to try as much as possible to vaccinate the highest risk individuals. And basically, we receive guidance from the FDA and the CDC about categories of individuals that are high risk. 1A would be frontline healthcare providers and people that work or live in long-term care facilities. And that's about 550,000 people in Wisconsin. The next group, 1B, would be essential workers, frontline personnel. And this has been redefined for people over 65 and older. In Wisconsin, that's over 1 million people. And in the US, phase 1A was 21 million people, and phase 1B was another 49 million. So more people than we have vaccine. We're hoping to move to phase 1C sometime in the next month or two. That's largely going to depend on whether the Johnson & Johnson EUA is granted later this month. But we do expect phase 1B to be expanded March 1 in Wisconsin to include other essential workers whose jobs require them to interact frequently and in close contact with the public. So that would be transportation workers, grocery workers, teachers, and educators, and frontline folks like our mail carriers. Next slide, please. Again, a little bit more vaccine information. I've already talked about the data on the left-hand side of the slide, but I did want to mention something that was carried in the journal Sentinel yesterday. When you look at the number of vaccines being administered per capita per day, Wisconsin now is #1 in the country, with over 6,000 vaccine doses being administered per million people per day. And so again, I think even though we were concerned in late December and early January that we might be lagging, we've now surged ahead. So I want to point out another screenshot from the Department of Health Services website on the right-hand side of the slide there. You can see growing numbers of vaccinations as we've gone through the last 5 to 6 weeks. I also want to show that we're getting more Moderna vaccine, which again is less fragile and poses fewer logistical challenges into getting it into the hands of frontline vaccinators. So the Moderna vaccine is shown in the purple bars, and the Pfizer is shown in the tan bars. And as you can see, not only are we increasing the number of vaccinations per day, but as a proportion of vaccines administered, we're getting more Moderna. And I think that's very, very important. I want to say that both vaccines are very safe and very effective. There's no real difference there other than the ease of administration, transportation, and storage. Next slide, please. Now, just to talk a little bit about early vaccine experiences and findings, and then I will switch to talk a little bit about the mutations that are being detected. So right now, there are no indications of severe negative outcomes related to COVID-19 vaccinations. And I believe we're approaching 40 million doses administered in the US now. Anaphylactic events, which were of significant concern in the first few days of the rollout in the UK and in the US, really have proven to be relatively rare. Most have been associated with people with previous significant food or medication allergies. And in fact, pretty much everybody early on who had a severe reaction carried an EpiPen. Most of the folks that have been affected are female, but the rate is actually very low, 5 or so per million administered doses. So we're still taking precautions. People are being monitored for 15 to 30 minutes after they receive their jab. And there is a healthcare provider who's typically there, who's capable of assessing the patient and administering steroids, epinephrine, and a histamine 2 blocker. But again, I want to emphasize that the safety profile of these two mRNA vaccines is quite extraordinary, very good. Now, we're also starting to see some very positive data supporting the effectiveness of rapidly decelerating the pandemic in some countries. So I think Israel is a good example. They had a mass vaccination program that was very, very rapidly administered, and they saw a significant downturn in the number of cases and hospitalizations and virtually no deaths within the first few weeks of that program. Now, I do want to emphasize that when we talk about historical data for COVID-19, we all need to say, when did this happen? Where did it happen? And who was the population? So I want to make sure everyone knows, in Israel, when these studies were done, there was virtually no penetration of these new mutations. So this is the old or original COVID-19 strain that we're talking about, not the UK and not the South African strain. Next slide, please. So I want to talk about mutations briefly. I think most of you know viruses mutate naturally. They all do that. They're trying out new versions of themselves to see if they can get a competitive advantage. And we know that COVID-19 mutates more slowly than seasonal influenza strains. But because we have a very high case burden, the opportunity to mutate is much higher. Every time that virus replicates is an opportunity for mutations to happen. So you're going to see much more rapid development of mutations if the pandemic is out of control. So there have been at least 4 different COVID-19 mutations that have been identified. And what's of significant concern to us is that they're called converging mutations, all in a very small piece of the COVID-19 spike protein, which is what the virus uses to attach to human cells and to invade us and create an infection. And the strains that are being talked about the most are the UK, or the B1.1.7 strain, and the South African strain, which is the B1.351 strain. There are other strains. One was a Brazil strain that was detected in people that traveled to Brazil and went back to Japan, and a new strain emerging in the US. All of these appear to be more contagious than the previously circulating strains. Now, this isn't conceptually different than one of the mutations we talked about back in the spring and early summer called D614G, which was a mutation detected early in China, which for a long period of time became the predominant strain in the world. And later a mink mutation that was detected in Denmark called cluster 5. I want to swing back to the UK and the South African variants. There is emerging evidence that the UK B1.1.7 strain may actually increase mortality for men over 60, but it's actually a fairly small number or percentage increase. And the data are somewhat inconsistent, but this is a good reason why we need to monitor with good surveillance, the different strains that are circulating in our community. Also, probably even more troubling are some data emerging on the South African variant, the B1.1351. That variant has several additional mutations, some of which overlap with the UK strain. And because of that, there's some concern that because the burden of mutations on that protein are growing, that it won't be as easily recognized by the vaccines that we have in the immune response that we generated. And in fact, that could even apply to the immune response generated from a previous infection. And we do know now that the B1.351 mutation is less affected by currently available monoclonal antibody drugs, Regeneron and Lilly drugs, and convalescent plasma. If I could go to the next slide, and this will address some of the concerns that some of the virus variants might actually evade immune surveillance from the vaccines that we're getting. So the South African strain, as I mentioned, has multiple mutations in the spike proteins. As of Sunday, there was preliminary data released in a preprint form of a study by Witwatersrand University in South Africa of a small number of people, 2,026, suggesting that the AstraZeneca Oxford vaccine is less effective in stopping mildly symptomatic COVID-19 infections in young people. And the average age of that small number of people studied was only 31. And because of that, they paused the rollout of the AstraZeneca Oxford vaccine in South Africa. So they're focusing primarily on rolling out the Johnson & Johnson and the Moderna vaccines there. Now, I want to get back to understanding the data in terms of when and where the data were obtained, who was studied, and what was actually studied. So this study did not address moderate to severe COVID-19 infections and was skewed to a low-risk age group. This happened in South Africa, where we have a new variant strain that is of significant concern to us. However, we do know that neutralizing antibody activity of the AstraZeneca Oxford vaccine was comparable to Johnson & Johnson for this South African strain and to the Moderna vaccines. And we also know that these two vaccines have been shown to be effective at preventing severe disease. Now, I will say with a caveat, albeit less effective than they are against original strains of COVID-19, there's still very, very significant protection. So from the perspective of our currently available vaccines, for the most part, I think it's safe to say that the South African strain has not yet escaped immune surveillance, and we should continue administering the vaccines on hand as rapidly as possible. And again, my final advice to everyone is just because you've been vaccinated doesn't mean that you can change your behavior. Until we get the pandemic under control, until we understand the impact of the variants, these new mutations that are emerging and will emerge over the next few months, people need to practice good precautionary measures. The 3 W's: wear a mask, wash your hands, watch your distance, and also, as much as possible, avoid non-essential interactions with people outside of the home. And with that, I'll turn it back over to Tim.
Thanks very much, Dr. Raymond. You've done a great job, as usual, and answered the questions that are in the chat just through the presentation. So I've got 2 quick ones. One question that came up is there a list that you can get at publicly that shows you the ingredients in the vaccine?
Yes, both Moderna and Pfizer have listed the ingredients. I think the one people are concerned about is a preservative called thimerosal, which is frequently cited as a problem by the anti-vaccine groups. That is not, there's no preservative like that in the vaccines. They're basically some lipids and some stabilizers and some salts. I don't have a web link for you, but you should be able to find it on Google pretty easily.
Great. And then I'm assuming your last admonition covers if there are 2 spouses and one's vaccinated and the other's not, you still want to be protected.
Yes. Until the pandemic, until we have achieved herd immunity, which again is 70 to 80% of the people having been vaccinated, because they'll have a good durable immunity. And the pandemic is under control, meaning that the burden of disease in the community is low enough that we don't overwhelm our public health capacity to identify cases and then do contact tracing and quarantining. We should not change our behavior. We need to continue to be safe.
Great. Well, thanks very much, Dr. Raymond. And I know you'll explore the Q&A if there are questions in there that pop up, and we'll pivot here and bring in our two chancellors here as we look to envision a competitive region that fosters high value employment to sustain a vibrant quality of life